Thank you for joining the National Headache Foundation's Pediatric webinar. Today we're joined by Dr. Howard Jacobs of the University of Maryland Department of Pediatrics. Dr. Jacobs, thank you for joining us today.
Thank you. Good evening, everybody. I hope your weather is better where you are than it is where I am. We're getting a ton of snow here. But anyways, I wanted to talk tonight about non-prescription treatments for migraine. We see lots of patients, most of whom go on all sorts of different medicines. We have a fair number of people who want other alternatives, and then certainly there are plenty of people who never get to a specialist and wonder on their own what kind of things they can do to take care of their migraines. So I thought I'd talk to you all about that tonight. I'm supposed to tell you I have no conflicts of interest to disclose. I'm not employed by any drug company or other outside influence. So we can get started. So we'll start with non-prescription migraine therapies, as I said. We can talk about acute pain relievers, you know, the ones you all know of, over-the-counter medicines. And then there are preventive therapies for people who need more than that, who need something to keep them from getting headaches. That would be magnesium, supplements and vitamins, herbals, and then there are combinations of those things. So let's start with the acute pain relievers. Is there something that works? So what are our options? There's acetaminophen, or Tylenol. It's a good pain reliever for mild pain, as I'm putting here, but it really doesn't do that well with severe pain. The other drawback is it's not very good at taking away inflammation. Inflammation is irritation of the nerve endings, especially in migraine, and the nerve endings around the blood vessels are particularly irritated, and acetaminophen doesn't really do much about that. You have to be careful with the dose on Tylenol. You cannot exceed the recommended dose because there is an overdose risk. It can cause liver failure, and in rare cases, even small overdoses can be fatal. So unlike some of the other medicines I'm going to talk about, you cannot go over the recommended dose with Tylenol. More importantly, it's been studied, and there's, as it states here, poor evidence for acetaminophen as a migraine therapy. So this is one I don't particularly recommend. The next group would be what are called NSAIDS, or non-steroidal anti-inflammatory drugs. These would be ibuprofen, Advil or Motrin, and certainly there are others, naproxen, which most people buy as a leave, and then good old aspirin, surprisingly enough, works quite well. So let's start with ibuprofen. Obviously it's easily available. Every pharmacy has their own proprietary brand of ibuprofen. It's been studied quite a lot, and there's limited evidence that it works. The issue is you need to use high enough doses. We'll talk more about that later, but in any of these medicines you have to use high enough doses to get your effect. Low doses just aren't going to work. Ibuprofen, however, the drawback is a lot of people get an upset stomach from it. Naproxen or Aleve, my personal preference. I use it a fair amount. I find it works well, and also because it's an every 12-hour medicine, it tends to last longer. I find that most people tolerate it well, although a small portion of people do complain of upset stomach from it. I generally don't have that with my patients, but it's something to look out for. Now there was a study that said it wasn't quite as good as ibuprofen. I personally don't agree with it. My own personal experience has been that it works very well, but you have to use relatively high doses. The over-the-counter naproxen is 220 milligrams, and it says that's an adult dose. For 12 and younger, I'll use 440, and for anybody over 12, I like to go up to 660 milligrams. And most people get kind of wide-eyed when I say that, but I do want to explain that prescription naproxen comes as 500 and 375 milligrams, and for sprained ankles and things like that, doctors will not hesitate to use 500 milligrams of naproxen or even higher. So I'm comfortable doing that. The reason for that is that when you have a migraine, your stomach doesn't empty well. So we have to go with somewhat higher doses to get the medicine through the stomach to get into the system to do what we want it to do. I recently saw a study from 2013 about aspirin, and as you can read here, it was more effective than placebo and provided sustained relief. Aspirin's gotten a bad rap over the past because in the 1980s there was a loose association made between aspirin and Rye syndrome. There's a lot of evidence now that points that one had nothing to do with the other, and aspirin really is quite safe for most people. But like the other NSAIDs, it can cause some people to have upset stomachs. But it does work quite well for headaches. So aspirin or naproxen, both are good choices. To be successful with these medicines, it's important you take the medicines as soon as possible. Any pain medicine works better to prevent the headache from getting worse and try and take it away than it will work when you're at your worst. When your head is hurting so bad that you want to pull your hair out, nothing really is going to help. So the key is take it as soon as you think you're starting to get a headache. As I said, the longer you wait, the less well it works. Higher doses may be necessary, as I said before, because the stomach doesn't empty well. But check with your physician to see what he or she considers to be the safe dose for you or your child. But with acetaminophen, never use more than the recommended dose. Now, here's an important thing. Do not use any pain reliever more than 3 days a week. Why? Because there's something called medication overuse headache. Migraine patients are particularly sensitive to pain medicines, and as I put here, anything from acetaminophen to barbiturates to codeines, if you take them more than 3 days a week, it can make your headaches worse and make them harder to get rid of. So do not take any pain medication for migraines more than 3 days a week. Now, having said that, before I came online, I was reading an article on use of naproxen for prophylaxis or prevention of headaches, saying that people did not have problems with it. So I may have to revise my thinking on that. But until there's more evidence, probably the safest thing is to just stay no more than 3 days a week for any pain medicine. And people say, well, what do I do on the other days? Well, if you're having headaches more than 3 days a week, you should be on something to prevent them, which takes us to the next part of the talk, preventive therapies. We're going to discuss mostly nutraceuticals. Nutraceuticals are those healthy medicines that are on that long counter in the pharmacy. There's some things you should know about nutraceuticals. They are considered dietary supplements, not drugs. As such, they don't fall under FDA regulations in the same way. So what does this mean? It means they're not monitored as well, and a bit of caution is warranted. The quality control is not as tight, and the amount of the active ingredient can vary. Even though the bottle says 300 milligrams, it can vary from 200 to 400, let's say. So you have to be a little careful with these. Let's start with magnesium. It theoretically has several roles in treating migraine, and there is thought that migraineurs have a deficiency of magnesium in the cells. Now that means it's not something we can draw a blood test and check. A physician can send a blood test off for your serum magnesium, but that reflects only the magnesium that's floating free in your blood. It doesn't tell us what's in the cells. But some studies have shown that there may be a deficiency. So the supplementation is 250 to 400 milligrams a day. I usually use 300 milligrams. It's quite safe. It may cause some loose stools. That's the worst thing. But you have to be patient. It can take up to 3 months before it really works. So you don't want to be calling your doctor 2 weeks later saying this stuff isn't working yet. You have to give it a bit of time. This is all from an article by Sun Edelstein and Moskoff. A lot of the following stuff will be from that article because it really is a wonderful discussion of the nutraceuticals. Supplements. Riboflavin or vitamin B2. 400 milligrams daily for 3 months. at least a 50% reduction in headache in over 50% of the patients tested. That's pretty good. Coenzyme Q10 lists 50% reduction in headache in 60% of the patients. And neither of them had particularly significant side effects. These are from these two articles. Herbals would be Butterbur or Petis. We'll just stick with Butterbur. I have trouble saying that one. It's an herbal. You can't take it in its raw form. It has to be processed. The action is not particularly well understood, but twice daily it reduced the number of headaches per month in a study. It's well tolerated. Excuse me. Then Feverfew is another one that's often talked about. However, this one, the results have been kind of come and go. Some say it works well, others say not so much. That one, there's one article that said this small dose 3 times a day was better than placebo, but it's contraindicated in pregnancy, and of all these, it's the most likely to cause allergies. Now, there are combinations of these things available. One is Migrelief, which is magnesium, riboflavin, and feverfew. It's nice because it comes in both adult and pediatric strengths. And then Migravent, which is a little different, and I prefer the Migravent. I think the combination of stuff in there is probably better. Some of the pharmacies carry it. They're both certainly available online. I'd wanted to do a study on this a while back and contacted the companies. They're surprisingly small companies, and unfortunately don't have the funds to do a real prospective clinical study, which is unfortunate because it would be good to prove that these really work. But there's a lot of suggestion that they should, and the individual components all have been studied individually, so you would think that there should be a benefit from these. And now, as I stated previously, I guess you should consider that you can use naproxen on a daily basis for prevention, but I'm not quite as comfortable with that one. What other things can you do if you want to stay away from the prescription medications? These are other therapies that we use: acupuncture, yoga, biofeedback. The key with these, honestly, is it works great for some people and they don't work so well for others. It's kind of dependent on how much the patient believes it's going to work. If someone says, that tells me that acupuncture, they're going to stick needles in me and you expect that's going to work, the answer is, well, probably not. But if a patient goes into it with the attitude of, there are millions of people who swear by this, I'm willing to give it a try, let's see what happens, there's a good chance it'll work. Yoga, same sort of thing. Biofeedback, there's been numerous studies that show that biofeedback in both relaxation therapy or CBT can be quite helpful. We have someone very good in our area doing relaxation therapy or self-hypnosis and have gotten good results from that. So these are other alternatives to the prescription medicines that we often use. Having said that, I'm quite comfortable using the prescription medicines and use them more often than not. Topiramate or amitriptyline are ones we very often use. Certainly ask your physician about those should they be indicated. And the indication is generally when kids are having headaches more than 2 times a week or for long periods of time such that they interfere with their school and life, then it's time for them to be getting something to prevent the headaches as opposed to treating them on the occasion. At this point, I'd be happy to open it up for some questions.
All right. Thank you for that presentation. It looks like we have a few questions coming in from our online community. Okay, our first question comes from Cheryl. Can you describe what is happening when a child is experiencing a migraine, particularly what's happening within the body when a child, not necessarily the triggers, but what is happening in the body?
That's a difficult one. There's been a lot of theoretical things going back and forth. For a long time, people thought it was what's called a vascular headache. The blood vessels in the brain were dilating, and because there's limited room in the head, it was causing pressure, which was causing the pain. It turns out that's been shown not to be the case. There is like an electrical depolarization going on in the brain. There's a wave of electric activity that goes through the brain that causes irritation of the nerve endings by the blood vessels, which can cause the throbbing. It varies from patient to patient, honestly, and it varies with the type of migraine. Migraine with aura is a little different than migraine without. Most kids and teenagers get migraine without aura, so they don't have a warning sign. But that's basically the pathophysiology. It's kind of complicated, and to be honest, I spend more time treating the kids than worrying about what causes it specifically, because it's kind of hard to address that. But an excellent question.
Thank you. Our next question comes from John. My son typically does not eat when he is experiencing a migraine simply because he says he has nausea. Is it typical to still want to eat despite nausea, or is it possible that eating could decrease that feeling for him?
Most patients, when they have a migraine, don't want to eat. Migraine specifically is defined as a bad headache with what are called autonomic signs. And the autonomic signs are dizziness, light sensitivity, sound sensitivity, nausea. So the great majority of people will get nauseated when they're having a migraine. Some even throw up. And it's not at all unusual for people not to want to eat. And even looking at food can make them feel worse. So it is part of the process, and not particularly unexpected. And I certainly wouldn't try to push the child to eat in the midst of a migraine. If he wants to, certainly okay, but I wouldn't push it.
Thank you. Our next question comes from Holly. My 14-year-old son was on 100 milligrams of amitriptyline and was put on Prozac for depression, and he began having migraines almost every day. Is there a connection here?
That's interesting. I have trouble making a connection there. A lot of people with migraines get anxious or depressed either because of the migraines or have that going on along with and maybe be what's causing the migraine. So it can go either way. So it's very often that we're putting our patients on medicines like amitriptyline, and then also a medicine like Prozac or one of the other antidepressant, anti-anxiety medicines. It's seldom that I see them make the headaches worse, but you know, every patient is different, and without knowing exactly what's going on, it's certainly possible. If you look at the physician's desk reference, the PDR, on every one of these medicines, one of the side effects will be headache, which we kind of joke about because people come in with headaches, and if their headaches are still there while we're treating them, it doesn't mean the medicine gave them the headaches. But this case is a little different. I would wonder whether the Prozac has something to do with it, and it might be worth trying to wean him off the Prozac and trying a different anti-anxiety medicine and see if maybe he doesn't have as much problem. But I don't know. Interesting question. Thank you.
Our next question comes from Alan. You noted that oxycodone may be used for acute migraine. What are the indications and contradictions for codeine products in adolescents with migraine?
I noted that they've been used. I didn't say that they should be. Okay. I try terrifically hard not to use barbiturates and codeine-containing medicines for headaches. The risk of medication overuse headache is particularly high with those. The risk of addiction is higher, although most people know that and don't use it that often. And I find that medicines like the amitriptyline and sumatriptan and the other triptan medications, which are the mainstay of what we use for acute migraine, work just as well, if not better, with much less risk. So in the years I've been doing headache, I have yet to use codeine for someone.
Let's see, our next question. Why do insurance companies only pay for 9 doses of Imitrex? Is there any danger in taking more?
You and I should go talk to them. Really, there isn't. The only danger is that we don't want anybody taking it more than 3 days a week. Now, you can take it up to twice a day, so that's a potential of using 6 pills in 1 week, which means that for 3 weeks, for 2.5 weeks, you're not going to have medicine. So this kind of makes us crazy. It's not particularly dangerous. Some people do get side effects from it, but that's usually immediately noted. People complain of it gives them sort of hot feelings when they take it, or tightness in their jaw and chest, and some people it makes their headache worse. But we know that immediately, and we stop it. There's no addiction risk with it. There's no risk of any other significant side effects outside of the immediate ones. So I honestly can't tell you why the insurance companies do that. I wish I knew.
Our next question comes from Heather. My daughter has a chronic...
I do know. It's to save money, unfortunately.
Oh,
yes.
That makes sense.
Go ahead. I'm sorry.
Heather says her daughter has chronic migraines, and she's currently in a migraine that started December 2nd. This migraine is different in the sense that it's at a high pain level, only going up in pain, but not dropping to a more tolerable pain level. Do you have any suggestions to confuse or disrupt the cycle? Her previous treatments have not worked.
Well, that's a very hard question because I don't know what her previous treatments were, and I'm obviously not seeing her. When we have patients who are really not responding to the home medicines, we can bring them into our emergency room, and we have a protocol of intravenous medicines we use, which generally works. I don't know if that's appropriate in your daughter's case. There's also, to try and keep the children out of the emergency rooms, we can use a longer acting triptan called naratriptan, and do that for 5 days along with a steroid for 5 days. That's something my partner and I do, and a lot of times it will keep the children, it will break the headache and keep them from having to go to the emergency room. But if it doesn't work, then we bring them in. There's some other things that are on the market that may work too. One is called a DHE nasal spray. We don't use it a lot, and frankly, some people don't tolerate it all that well. It's one of the things we give in the emergency room via IV, and it tends to work very well in that setting. But some people also respond to it in the nasal spray form. Those are all things you could discuss with your physician. He or she may have specific reasons why they don't want to do that, which I wouldn't know. But those are the things we often do here in Baltimore. Best of luck to you.
Thank you. Our next question, what are the indications for imaging in children with migraine, and what imaging is appropriate?
The indications for imaging, interesting, I just wrote an article on that. There are very few. Basically, when we see a patient, we're taking a history and we're looking at a patient. And if the exam of the patient is normal and the history is consistent with the migraine, there really is very little indication for imaging. On the other hand, if I look at a patient's eyes, which is probably the most important part of the exam, with the ophthalmoscope, what I'm doing is looking at the back of the eyes. If something is in the head that's exerting pressure, it will push on the back of the eyes, and generally we can see that. And based on that, we can say there's something going on, we better get an image. But that's relatively seldom that that happens. The other indication for imaging is after an injury, post-concussion headache, when the child shows up in an emergency room. In that case, a CT scan is the best way to go. It's quick, it's easy, and if there's bleeding, which is what you're most worried about, you will see it. However, if I'm worried that there's an intracranial process, a process in the brain that's more chronic, generally an MRI is a better study. It gives better views of all of the brain, including the very back part of the brain, which does not come up well on a CT scan. I can tell you it's seldom that I have to do that, but if the story doesn't sound right, excuse me, or if I have any question about the exam, then it's time to get an image. But if, in the face of a history consistent with migraines, headaches associated with nausea, photophobia, light sensitivity, sound sensitivity, with a family history where mom or grandma or dad had headaches that were similar, it's rare that we want to get studies. Unfortunately, sometimes they show things which are benign and have nothing to do with the headache, but cause us more consternation and time explaining why it's not important. So if you don't know what you're looking for, don't look for it. I hope that answers your question.
Our next question comes from Tom. What is the recommended dosage of Migraine?
I think it's 1 tablet twice a day. I haven't used it recently, so I couldn't swear to that, but I'm pretty sure it's 1 tablet twice a day.
Thank you. Our next
and
question.
And it's certainly on, when you go online, it will say. Yeah, I'm sorry. Go ahead.
Oh, I'm sorry. My son has had migraines since he was 5, and he's been on amitriptyline for 4 years. The onset of puberty and at the beginning of high school made them much worse. They tried Topamax, which had a terrible side effect, and now they're talking about Depakote. Do you think this is safe for a teen along with Prozac?
It's safe. I will tell my patients any medicine I put them on or any other doctor puts them on has a potential for side effects. Amitriptyline is a great drug. Topamax for most people is a great drug, but some people do have significant problems from it. Depakote is a good drug, and it works very well. The side effects from Depakote that you have to watch for is it can cause kids to gain a fair amount of weight. So you have to watch their diet, get them on the scale once a week to make sure their weight isn't skyrocketing. There are certainly other medications that can be used, but they also have side effects. Propranolol is something that's been used for a tremendously long time for migraines. Unfortunately, if a patient has asthma, you don't want to use it because it can make their asthma worse. Gabapentin or Neurontin, same thing, gets used a lot. It's another seizure medicine. Excuse me. It can also increase appetite a little bit. So there are other options, but Depakote is not an inappropriate one, and a lot of kids do quite well on it. A good question. Thank you.
Thanks. Our next question comes from Maggie. Have you had any patients to take Lepogesic, and have they had any success?
Maggie, no, I haven't. I've seen it. I know it's there. I just haven't had the opportunity to use it, so I can't say whether it's good, bad, or indifferent. The marketing people tell me it works great. Just hasn't been one of those things I've come up to use yet.
Thanks. Our next question comes from Cheryl. What is the difference between cyclic vomiting syndrome and abdominal migraines?
Mostly it's the age. We tend to see cyclic vomiting in younger kids and abdominal migraine in kids who are a little older. But there's a huge crossover. Cyclic vomiting is episodes of vomiting that won't stop more than 4 times an hour, and the kids often end up in the hospital to keep from getting dehydrated. Abdominal migraine is, again, older kids who complain of vague stomach aches, usually centrally, not associated with vomiting or diarrhea. Well, not associated with diarrhea. Occasionally they'll be vomiting. And generally those kids we don't see for a couple of years because they've already gone to the gastroenterologist and been scoped up and scoped down and had all these studies done, and we now know they don't have inflammatory bowel disease, and they don't have celiac disease, and they don't have, and they don't have, and they don't have, but they still have these episodes of achy, miserable abdominal pain. And then somebody says, does anybody in your family get headaches? And they say, yeah, my mom gets migraines. It's like, and the light bulb goes on. And then we say, okay, why don't we treat you as though it's a migraine and see if it gets you better. All that said, I have older kids with cyclic vomiting and some younger kids with abdominal migraine, but generally it's 4 to 7-year-olds with cyclic vomiting and 8 to 12-year-olds with abdominal migraine. But that's quite variable. Good question. Thank you.
Next question is from Melissa. I have a 13-year-old daughter that has had her first migraine that lasted 5 days. Tylenol and ibuprofen and naproxen were all ineffective. We tried steroids and that seemed to help break the cycle. But what should we do in the future if it happens again? I have a history of migraines. Her doctor has wanted to try Lortabs, but I don't think that's a good idea.
Yeah, I'm not crazy about Lortabs either. The question would be how much of the, I would say Tylenol is something I wouldn't use. It's not likely to help. Ibuprofen or Aleve, can help. As I stated in the talk, I kind of lean more towards Aleve, but you have to use a high enough dose, and you have to hit it quick. I think if you gave 440 to 660 of naproxen, that might well work. On the other hand, the other consideration is using a migraine-specific medicine, a triptan. Imitrex is something that many people have used and many people are familiar with, and it works quite well for the great majority of kids with migraines. Some kids it does not work so well. Some kids don't like the way they feel when they take it, as I was stating during the talk. But it's something we use quite a bit. There are other triptans, other medicines in that class. One is called Maxalt, which has been which is almotriptan, which has been approved down to 12 years of age. I should tell you that sumatriptan, though pretty much every headache doctor in the country uses it with kids, it's not approved under 18, so you would be using it, as they say, off-label. So, I do want you to be aware of that. It's quite safe, and it really shouldn't be an issue, but it still is. But you could consider trying, seeing if your doctor is comfortable using a triptan, like almotriptan, and see if that works. But steroids sometimes, when nothing else works, steroids sometimes can break it, and but hopefully trying some of these other things might keep you away from having to do that. Next question.
See, our next question is, what is the preferred dose for amitriptyline for a 14-year-old girl? Currently, her dose is 20 milligrams, and she seems to be tolerating it well, but she still suffers from chronic migraine.
Amitriptyline seems to work best at about 1 milligram per kilogram, which is then 2 milligrams per pound. Go in the right direction. So it varies. 20 milligrams is a fairly low dose. I will generally start at 10 milligrams and walk up by 10 milligrams every week or two until I either get the migraine under control or I get side effects. The maximum dose I will use is 100 milligrams. There are people who prefer to stay below that. I don't have any concerns about going to 100 milligrams myself. But you have to watch out for the side effects. The side effects of amitriptyline are that it can make you quite tired, which is why we give it at bedtime. And generally that's all we have to do. The kids sleep it off. But There are occasions when I get parents telling me that it's very hard to get their children up in the morning, and obviously that can be a problem. Generally, when that happens, I suggest that the families give the amitriptyline to the kids at dinner time, and usually then it'll wear off before they wake up. So that's the first problem with it. The second one is it can increase your appetite, and a lot of teenagers are obviously concerned about that. So if you go up, there is a risk that you'll cause some weight gain, and it can make their mouths feel dry. But I don't mind that because I want my kids drinking lots of liquids anyways. I want them drinking enough that when they go to the bathroom to pee, their pee is clear, because your heart's pumping energy up to your brain. The better hydrated you are, the easier it is for that to happen. So the answer to your question is 20 milligrams is a relatively low dose. It's okay. I would be comfortable going up higher until it works. A lot of general pediatricians and family practice doctors are not that comfortable with it. And if they're not, then it might be worth seeing if there's a headache specialist or a neurologist who your child can see who's more comfortable doing that. I'm uncomfortable working with digitoxin, but the cardiologists are very comfortable with it. They're uncomfortable using amitriptyline, but that's where I'm comfortable.
Thank you. Our next question comes from Dennis. My 18-year-old daughter is experiencing chronic daily migraines. She complains about eye pain as well as pain when she touches certain parts of her head. Do you know what this is called, or what's the cause of it?
Yeah, a lot of people with migraines complain of pain behind their eyes. And unfortunately, because of that, a lot of people end up getting treated for sinus infections when they really have migraines. So that's unfortunately not that unusual. The other symptom is called cutaneous allodynia, which means being touched in a way that shouldn't hurt causes pain. And that's a sign of a particularly severe migraine. So what you're telling me is your daughter's suffering a fair amount. And it's probably time to get her seen, if you haven't already, and get her on some stronger medicines to try and get it under control.
Thanks. Our next question. Do you find a particular personality type in children who suffer from migraine?
It tends to be kids who are more driven, the A-type personality. And part of that is because they tend to come from families who are also A-type personalities, and everybody's pushing, everybody's trying to do better. It's a lot of stress as you try to do, to be in 5 different activities and school and work a job and have your church group or whatever. And all of a sudden the kids are getting overloaded. And the stress makes the migraines worse. Stress is a definite cause of migraines, or contributor, I shouldn't say cause, but definitely contributes, which is why we talked about relaxation therapy in my talk. It's to try and get the kids to relax and settle down a little bit. But sometimes we have to say, you're just doing too many things. You really need to pick out which is most important to you and try and get some time to relax. We see that a lot. A lot of these kids are spending too much time in front of computer screens playing games, and the stimulus from the computers tend to get to them after a while. Unfortunately, that can be pretty hard to break because very often that's the only thing that makes them feel good is when they can play on their computer, and I'm telling them you need to stop doing the one thing that you enjoy while you're having your migraine. But generally, I find it's the A-type personality, the overachiever.
Thank you. Our next question. Have you seen that adolescents can suffer from cluster headache as well as migraine?
I have seen an adolescent who has something similar to cluster. Cluster tends to be in men, although more women are getting it now, and there's a good question as to why that's happening. But there's a similar process called paroxysmal hemicrania, and it tends to be shorter episodes of eye pain and eye symptoms, and I have seen one young lady with that. The nice thing about that is it's treated specifically by one drug, indomethacin, and it works. And it worked well with this young lady. But I haven't seen kids with cluster. I know they're out there, but I haven't seen it.
Thank you. Our next question says, what percentage of boys grow out of migraines, and at what age do they usually grow out of them?
Well, interesting enough, boys tend to have the same likelihood of getting a migraine, if not even a little bit higher likelihood in childhood. Once you hit puberty and hormones get involved, then girls tend to have a lot more of them. As far as when kids grow out of them, always a tough question. Some patients I can put on medicines and then wean them off of them after 6 to 9 months and they never come back. Other kids, they're on medicines for much longer. You know, and there are the kids who grow into adulthood and need to be on medicine to keep from getting migraines. So there's no hard and fast rule to say that generally by 15 boys will grow out of their migraines. I can't give you that. I wish I could. But what we like to do with kids who have lots of migraines is we put them on a medication to prevent them. We keep them on it for 6 months to 9 months, and then try and slowly wean them off the medicine. Sometimes it's a steady process of going, let's say, from 50 to 40 to 30 to 20 and on, you know, and down. Sometimes it's not so steady. We go from 50 to 40, everything's fine. Go to 30, everything's fine. Go to 20, they're getting more headaches. We go back up to 30, stay there for a couple months, then try again. Basically, it's like putting a cast on a broken bone. You know, the medicine is to allow your brain to rest and get better, but then after a while you want to take the cast off. But when you take the cast off, it doesn't mean that you can now run a marathon now that you've got the cast off your ankle. You've got to slowly work into it. And so we have to slowly take the medicine away to try and get the kids off of it. And sometimes it just doesn't work that well. Usually it does, though. I want to thank everybody for joining me tonight. You had some great questions. I hope I gave you some information you can use. Certainly feel free to send me an email. I'm more than happy to answer them. I'm happy to guide you. I certainly can't prescribe anything without seeing a patient, but I'm happy to give you some ideas if you have questions or just ask